Hello and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. My name's Gillian Whiting and I'm your host, coming to you from Meanjin, the land on which this podcast is being recorded.
And I'm Dr. Maria Bolton, GP specialist and former president of AMA Queensland.
Today we're joined by Professor Paul Griffin, Mater's Director of Infectious Diseases.
Paul is a leading infectious diseases physician and clinical microbiologist who became a trusted authority on vaccine education and advocacy during the COVID-19 pandemic.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
Paul, welcome to sMater.
Thanks very much for having me.
We're keen to tackle quite a few topics today, including long COVID and the flu, but can we start with RSV and what we're seeing so far this year?
Look, it's interesting. We're seeing quite a lot from a number of respiratory viruses, but RSV in particular, we are seeing quite a lot of cases already and unfortunately quite a few hospitalisations. But of course, the biggest thing that's changed with RSV is we now have a lot we can do about it. So that's really the message we're trying to get out there right now.
Why is its prevention so complicated?
Look, for a few reasons. It was a real challenge to make an RSV vaccine. So we discovered RSV in the 50s, and it's not like we only just thought up making a vaccine in the last few years. The first vaccines, very crude, caused some problems, so that set RSV vaccination back a long way. And we needed quite sophisticated sort of molecular biology techniques to make the kind of really clever, highly effective vaccine that we now have. But all those things have happened and we now have a number of different interventions. But at the moment, the uptake's been a little bit slow, so we want to get the message out there.
In February, we welcomed the inclusion of the RSV vaccine of Brisbane, the NIP for pregnant women. It's early days, but are we seeing the desired immunological response in newborns? And what are the long-term benefits of the vaccine?
Yeah, too early to see a direct impact of the rollout that started. I mean, we were so happy that announcement came. We've had these vaccines for a little while, but until that announcement in February, none of them were funded. So that was a big barrier to their uptake. So very welcome announcement. We're seeing some reasonable uptake, but not where we want it to be. And in terms of actually translating that into outcomes, it's a bit early, but we certainly anticipate that will be the case.
In addition to this, we've had the monoclonal antibody treatment nirsevimab that's also been made available for babies and infants at risk of RSV. And Mater, as well as the other hospitals, have been offering to newborns since last April. What do we know about the impact this is having on RSV cases and admissions to hospital?
Yeah, we know it's had a huge impact. So us and others are measuring what we've seen, and there was some information put out by the government early on in the season last year that there'd still been 90 babies admitted to hospital with RSV, but not one had received nirsevimab. And so that was a reduction of nearly 50% on what was expected compared to previous years. So truly having an amazing impact. We've had a bit of a look at some of the information around the uptake, and it's not been as high as we'd like with that either. And now one of the big challenges is it's a really complicated system with a sort of national NIP-funded vaccine and a state-based funded antibody and who gets what. So, I think we need to do a lot more to educate everybody about these preventative measures and where they all fit in. But yeah, when we look at the impact of nirsevimab, it's been huge. And so it's really great that now most states have access to that.
Are there any limitations on stock?
My understanding is that there were some challenges early on, but at the moment, not really. So I think the biggest challenge is knowing who's giving it and when. We looked at some of the data and some people missed out early on and then we weren't sure if they got it later on.
Are we any closer to having a vaccine that is approved for babies and infants?
Yeah, look, that's a bit of a tricky one. So, given we have maternal vaccination, now we have nirsevimab and that's so safe and effective, I think the momentum for developing vaccines for younger babies has probably slowed down a little bit. So there's nothing imminent as far as I'm aware. I mean, maternal vaccination is such a good strategy because you kind of get a 3 or 4 for 1. You protect mum, you protect the baby directly. It's a bit of cocooning, so baby won't get it from mum, and then even maybe some transfer of immunity through breastfeeding. So it's such an effective strategy that then trying to additionally vaccinate the babies, there's probably a little bit less momentum to have to do that in addition.
Let's talk about trials, and Mater's also part of a first in human trial using an experimental mRNA vaccine designed to prevent RSV in participants aged 60 to 75. What can you tell us? How's the trial progressing?
In terms of some of our vaccine work, it's always hard to comment too much until the trial's completed and the data is analysed, and that can take, up to 12 months after to make sure we rigorously put all that together. But, our vaccine studies, including that one, are going really well. We've got a community that's supportive, so we recruit lots of eager people into our studies and obviously carefully monitor them. So a bit too early to report on results, but it's looking promising.
Older Australians are at risk of severe disease when it comes to RSV. There is a vaccine available, but the cost is really prohibitive. Is there any moves to fund it?
The biggest change with one of the RSV vaccines is they were initially both approved for over 60s, and about 2.5 weeks ago, one of those was expanded to be available for people 50 to 59 with risk factors. But in Australia, we've got this complex system. They get approved by the TGA, so they're available. They get kind of recommended by another group, and that adds a layer of complexity. And then the funding piece is very separate. And there's always a lag. So they never happen one straight after the other. So to get something funded, there has to be a really detailed, robust evaluation of cost effectiveness. And even though we know the vaccine's safe and effective, it's not always determined that it's cost effective in that group. So we're still waiting on that. There's lots of people lobbying really hard to get it funded because we know that, especially at the moment with cost of living, etc., that the cost of that vaccine is a real challenge. But in some of the discussions we've had around that, it's been really interesting, some of the anecdotes. So one of the best tips I think I had from a GP was don't tell people not to assume people can't afford it, because if they've seen a young baby with RSV or they've had it themselves or a family member, sometimes people who probably can't afford it will still want to pay for that vaccine. So I think still recommending it, making sure people know that it's out there and how it fits in and how significant RSV can be is still really important.
And Queensland does seem to be ahead of the game when it comes to funding vaccines, right? Like we fund the flu vaccine for everyone.
Yeah, look, it's been incredible, and a shout out to everyone involved and to the government for doing that. And we have big meetings where we're talking about funding of these vaccines in other states, and they're really jealous of our situation here at the moment. The flu vaccine, as you say, funding that for everyone is amazing. Meningococcal is another great vaccine funding story here, and of course we were the second state to roll out the antibodies for RSV. So we're very lucky here in Queensland, and I just hope that it continues and we have certainty about those things moving forward.
On vaccines, what are the current challenges in developing a universal RSV vaccine?
It's great. We've got 3 options, so 2 options approved in Australia. There is another option approved in the US that might come here in time, and it's like a lot of vaccines. We're really lucky to have those, but there's a big shopping list of additional properties that we would like potentially. So a lot of work still continuing. I think at the moment what we've got is probably what we're going to have for some time. There's probably not a lot of movement there other than maybe combination vaccines that I'm sure we'll get to in a moment. So, I think just to be aware that the vaccine options we have now are safe and effective. Biggest barrier, of course, is cost, but we're really lucky that they're working really well.
RSV became a reportable virus to the National Notifiable Disease Surveillance System in July 2021, more than a year after COVID-19 was listed on the same register. RSV's addition to the list was driven by a combination of enhanced surveillance capacity, greater recognition of its health burden, and the emergence of new preventative strategies, all of which gained momentum in the wake of COVID-19.
I don't need to tell you this, but COVID arrived 5 years ago. I don't know whether it feels like yesterday or a lifetime ago. What about you?
Look, in some ways it feels like we've been doing it forever, and in some ways it feels like we're just getting started. And, the discussion around COVID is fascinating. I mean, it's really clear. So many people describe it as post-pandemic or post-COVID, but it's not going to go away, and it's going to keep being a problem forever. And I think that's really the mindset change that we have to bring in now, is that we want people just to incorporate this into what they do sensibly and practically to keep themselves and everyone safe every year, just like we've been encouraging people to do for the flu, and now we're doing for RSV as well.
So much has changed really in that 5 years, and including the variants presenting. So what's the next variant that we're keeping an eye on? How does it present differently to those that we're seeing at the moment?
Yeah, it's funny. I think for most people, they don't need to know what variant we're talking about. We can encourage people to leave that for a small number of people who are responsible for coming up with recommendations, because this virus is going to keep changing. There's thousands of Omicron subvariants now. The latest one, LP 8.1, is dominant globally, not yet dominant in Australia, but will be. And, the same discussion we've had probably 50 times now, we don't know whether that's going to mean we get a rise in cases from that subvariant or one in the future. But what we do know, inevitably, COVID will increase again. We're probably at the lowest numbers of COVID right now that we've seen, which is great. But that's not zero, and that's not going to stay that way forever. So COVID will keep coming, and we've got great interventions, but they're just being so dramatically underutilised.
What are the latest insights into how long COVID presents and presents differently across different demographics?
Yeah, that's a really challenging one. And, I think in the end, we'll discover there's lots of different types of long COVID. And basically, it's different for individuals. If you look at sources in the literature, they'll say there's 200 or 250 symptoms of long COVID, but basically it's anything. I think the commonest ones are sort of general things like fatigue and lethargy, and it's people that just can't do what they used to do. They're fatigued, like running a marathon would have been before. Daily activities fatigue them and leave them washed out. And then there's a lot of different organ systems involved. I think probably the next common ones, and it depends on which source you use, respiratory, so shortness of breath, even on doing things that wouldn't have been considered activity before, talking or walking, cardiovascular, chest pain, fast heart rate is really common, neurological things, and I think everyone's familiar with brain fog, but that means different things to different people. And then from there, it's anything. Some people can have musculoskeletal things, other neurological things, and even gastrointestinal things. So changes in bowels is something as well.
Has there been a shift in how long COVID presents? Because it seems that at the start of the pandemic, we're getting a lot of people with chest pain and shortness of breath, whereas now we get more the fatigue and the gut issues.
Yeah, I think so. A part of it's also a recognition thing as well, and the types of people we're seeing. And obviously, and certainly not suggesting COVID's not a problem, as we've already said, but the risk from COVID has declined. The number of people in hospital and dying is less, which is fantastic. So how we're talking about and thinking about COVID is a little bit different. So I think part of that is, maybe we're not finding a lot of them these days as well. And for so many, it's hard for them. We don't have the long COVID clinics like we did. It's not talked about as much. So there's probably an under recognition, which might be skewing some of those presentations. So yeah, it's complicated.
What are the current evidence-based guidelines for treating long COVID? Because we know that, these patients, they'll try anything, but where is the evidence?
Yeah, look, a tricky one. And, it's great there's a lot of research happening in long COVID. I'm part of the group assessing a whole lot of grants that are coming through for all sorts of different things with long COVID. What we really need, we need to understand the mechanism better. We need to be able to diagnose it better. And of course, what we want that to translate into is better management. And at the moment, we're really wanting in all of those areas. So, I think in terms of what's causing it, there's probably a whole host of different things. And maybe, a lot of it is an immunological thing, maybe a bit of an exaggerated immune response. And part of it is probably also a direct viral thing, so we're still working on it there. But in terms of approved therapies, basically we don't have any. There's emerging evidence that if people get metformin early on in their COVID, it probably reduces the chance of getting long COVID. But again, there's some controversy around that, so not suggesting we prescribe that. I guess the simple answer there is keep an eye out for guidelines when they come, when we do have approved therapies. But at the moment, no pharmacological therapies. But I think there's been a whole host of things that can help in my experience. And I think, first of all, having an understanding and appreciation that it's real, because a lot of these patients bounce between different people getting told there's nothing wrong with you. And I think that frustration and that need to be validated and have someone who can just listen to them is really important. I think making sure there's not something else going on, not just assuming, that's long COVID, because we don't want to miss things like PEs or thyroid issues, diabetes, for example. But then there's a whole host of multidisciplinary people that can really help, whether it's exercise physiology, physiotherapists, etc. There's a whole host of people that can help, and I think involving as many of those as possible, ideally with a long COVID clinic, but they're so hard to get into. But just, making sure that you understand and listen to those patients and do as much as you can to help them.
Is there any evidence for vitamins and supplements?
Obviously, if you're deficient in something, it will make a difference. So we certainly want to make sure people aren't B12, folate or iron deficient, for example. But if you're not deficient, taking all of those things, unfortunately, doesn't have a role necessarily.
Are we getting any closer to an effective long COVID treatment?
Look, I think we will get something, but I think because long COVID is probably so many different things, we might have treatments that work for some people and not others. And part of that will be working out who's got what type of long COVID or what's driving their long COVID to be able to address it more specifically. So I think we will get some therapies, but at the moment, nothing that's approved. I guess the one thing I will remind everybody is there's really good evidence that if you're vaccinated, you're less likely to have long COVID. It obviously changes the acute presentation, the likelihood of getting more severe disease in the short term, but it also has really good evidence for reducing your chance of long COVID. And, we know as a severity indicator, for example, if you're hospitalised with COVID and get long COVID, you're likely to have long COVID longer, so probably 9 or 10 months. If you're not, then your long COVID is likely to be shorter, so on average maybe 4 or 5 months. So again, the benefits of vaccination are really clear there too.
Is there any research going into the use of monoclonal antibodies in the treatment of long COVID?
There's lots of things, and if we look at it potentially having an immunological mechanism, we've got so many great ways of modulating the immune response with monoclonals now, and there's some work specifically looking at all types of monoclonals there. Again, it's relatively early though, and I think one of the things we need to do is be able to diagnose it better, maybe classify it into certain types, and then look at more specific interventions there. And there's lots of great work happening in Australia as well as elsewhere into a lot of those things. Hopefully we'll have some progress soon.
You mentioned before that COVID numbers are down currently. Does that translate to the chance of developing long COVID? Were we seeing more people developing long COVID earlier on in the pandemic than we do now?
Yeah, it's a bit complicated. So, it's fascinating. We talk about our case numbers now, but we know we're probably only scratching the surface with the real numbers that are out there. So, one of the ways we look at that is the proportion of tests that are positive, and we used to freak out when it got to sort of 6 or 7 before, because that told us we were missing a lot of cases, and it's usually 10 to 14 at the moment, so we know we're only finding a small proportion. So while we've had 60 odd thousand cases across the country this year, it's probably many times that. And then the proportion that go on to long COVID is very different depending on how you define it and what source of data you use. So most people would suggest it's probably around 6 to 10% of acute COVID goes on to long COVID, but if we're not finding a lot of the acute COVID, it's very hard to know. So, the actual prevalence of long COVID is really hard to determine.
What advice can we give patients who have symptoms of long COVID?
Look, I think the first one is to just provide reassurance that you will get better. Most people get better from long COVID. Most people, it's within a matter of months, and for the vast majority, it's within a year. So be optimistic about recovery. There's some work coming out about some other ways of approaching long COVID, and it's the 3 Ps, which is pace, plan, and prioritise, which really is about not overdoing it. So many times I get the story recounted that they feel really flat, they have a better day, so they go to the gym, mow the lawns, do the shopping, and then can't get off the couch or out of bed for 2 days. So it's about pacing yourself, holding back a little bit, planning your activities so that you can have breaks and spread things out, and prioritising, just understanding that you have some limitations, you're not going to be able to do everything. So pick the top things, get those done whilst planning and pacing yourself, and appreciating you can't do everything, and just giving yourself time to recover.
Do you have any advice for people who want to return to exercise, particularly those people who are avid exercisers, like people who do triathlons, etc.?
Yeah, the way I describe it to them is, for a lot of those people, doing a normal thing that you used to do, a day-to-day activity, will be like doing whatever event it was you used to do, and just think about it that way. So in essence, almost train to get back to having a full day, whether that's work or just doing normal things. Don't overdo it early, because that'll set you back, just like it would have when you started training for your marathon or your rowing event, etc. So think of your daily activities almost as an event to train for, and have a long-term plan in terms of getting back to what level of function you had before.
The thing that concerns me, Paul, is that it seems that people aren't aware that there are antiviral treatments for COVID, and particularly those people who are high at risk. But it seems that people aren't even testing anymore.
Yeah, absolutely. And, that's a great question and a really important point. So first of all, testing's become much harder to access. So early on, I think it was great. It was one of the big strengths of Australia's response, was that we just let people get tested without needing to see a GP first and waiting for the referral and then paying extra for that. The drive-through clinics, they were great innovations that made a huge difference. And of course, we've undone all of that now. So many people recount to me that it's just really hard. You've got to see a GP, get a referral, that there's a bit of a delay, and then there's a delay getting that test. And, the single biggest determinant of how effective antivirals are is how quickly they're initiated. So on that point, I encourage high-risk people to have a plan for how they get tested and get access to the antivirals ahead of their infection if they're in that risk category that they might benefit from that, because that way they can do that quickly and it's going to make a huge difference. And the other thing about testing is with, laboratory-based PCR, those nose swabs we all came to know and love that made your eyes water, we can find all sorts of things at once. And we have excellent antivirals for COVID, excellent antivirals for the flu, again, if they're started early in high-risk people. And then we have antibiotics for some of the bacterial things that can look similar, mycoplasma and whooping cough. All of those things are indistinguishable early on. So you don't know what someone's got, but we can do something about those. And then kind of as secondary gains, we also know what's out there. We can do excellent surveillance. That's how we know what subvariants of COVID are circulating. That's how we know what type of flu is around. So there's heaps of benefits to testing. And I think people have lost sight of a lot of that as well. And just also on the rapid antigen test, just so people know, there's actually combination rapid antigen tests as well. So that'll do COVID, flu and RSV. So they're really helpful, and especially if there's delays or people can't access a laboratory. The challenge with those is the sensitivity. And when we've looked at some of those, for flu B, for example, sensitivity of those combo ones you do at home is probably 30 or 40%. So the big message there is they're great, do them, and if they're positive, get your antivirals, isolate, etc. But if they're negative, don't assume you're fine to go and visit your sick relative in a nursing home or go to a hospital, because you could still have COVID, flu or RSV.
Yes, and I do have some of those in my drawer. What we do at our clinic and what some GPs do is that basically if somebody's at risk of severe disease with COVID, we put it in the comments section in the file. So if they ring up with respiratory symptoms, we know that they need to be fitted in, we know that they need to be tested, and we know that they need to be considered for the antiviral treatment as well.
Yeah, that's great. And I think the other message there as well, and one of the things that's probably contributing to, the high numbers of all these things we're seeing is either way, if people have symptoms, we want them to stay home. And, that was a message that was really effective during COVID. And, people probably remember if you went on a bus or in a public place and coughed or sneezed, everyone would look at you. And, so people were doing the right thing for a variety of reasons. But we used to say this every year for the flu, and people think they're doing the right thing soldiering on, but there's great evidence that doing that and spreading your COVID, flu or RSV in the workplace has a massive impact on productivity. So it's better if you do the right thing, stay home till you're not shedding and potentially spreading those things around, and then go back to work.
The Australian Institute of Health and Welfare reports that from the limited data available, current prevalence estimates of long COVID, defined as 12 weeks or greater, in Australia range from 5% to 10% of COVID-19 cases.
Focusing on the flu now, our vaccination rates have been described as dire. Our flu case numbers are tracking above the average for the past 5 years. So what does that mean for the flu season ahead, and what should GPs be preparing for?
The simple answer there in terms of what it means is worse than it should otherwise be. So first of all, on the numbers, so we've seen about 1.5 to 2 times the number of cases we would see for January, February, March and April. So a really big interseasonal period with flu. Now, a lot of people say, what does that mean for the season? Simple answer is we don't know what the season's going to bring until after, and we can reflect and look back. But it is a bit concerning, especially when you then factor in our vaccination rates. And we've touched on how great a job Queensland has done in terms of funding flu vaccines for everybody. Unfortunately, that hasn't translated into an increase, which is what we'd really like to see. And, if we look at our highest risk groups, so people over 65 and young children, we're tracking along at about a third of those people being vaccinated, which is really concerning. And, as I mentioned, that means that whatever the flu season brings, the impact will be greater than it should have been. We know flu vaccines aren't perfect. We know you can still get the flu after you've had a flu vaccine, but what we do know is that flu will be different in terms of your trajectory. You'll be sicker probably for a shorter period. You're less likely to go to hospital, less likely to die from the flu, and probably less likely to spread it as well. So if people want to know what the benefits of those vaccines are, it's really clear. And the fact that people can still get the flu is not a failure of those vaccines. And I think people need to understand that there's so much misinformation about flu vaccines and vaccines in general that I think that's part of what's impacting those rates.
I am concerned that it's quite an early season, but also it seems that those patients who are becoming sick with the flu, who are unvaccinated, are actually reporting really severe symptoms, and it's spreading quite easily amongst the family members, which is not good. I was just wondering, when it comes to vaccines, is there any research on what is best when combating misinformation about vaccines?
We haven't solved this. Otherwise, we'd have better vaccine rates. I think, part of it is understanding what people's concerns are. And, I think there's a there are those people that are what would have previously been labelled as true anti-vaxxers, and we probably can't change their opinion, and that's fine because I think they're actually the minority. But I think there's a lot of people that are a little bit confused because it's really complicated. We've got more vaccines for the elderly now. I often say that for older adults, it's a bit like being in the paediatric space because there's now a whole host of quite complicated vaccines that we recommend for that group. Paediatrics, we know, has always been complicated, and in pregnancy, there's now 3 vaccines we recommend for every pregnant woman. So it's just more complicated. So for many people, it's overwhelming. I think that's part of it. I think the amount of information that's out there is hard for a lot of people to digest, and I think for a lot of people, they're probably sick of talking about infections as well, and it gets called fatigue, although some people have said we don't want to describe it as fatigue, but it's just been too much maybe. So, I think that's a role that a lot of people involved in this space can really have in just reminding people, telling them how important these things are. And, our GPs do a great job of doing that every day, but we know they're busy and time poor, so it's hard to just rely on them. Pharmacists have a bigger role these days, but I think everybody just needs to know how important these vaccines are and do a better job of reminding people and encouraging them to get them every year.
Well, we heard earlier this season about the risk of the quaddemic, RSV, COVID, influenza and norovirus all striking at once. Is it still a risk, and what are the implications of all these co-infections?
That's the thing that makes every winter more challenging now is we used to struggle with the flu season every year, and we had a bit of a bad flu season. That by itself was enough to make our hospitals more stretched than they are at baseline, make it really hard for our GPs. We know that there's millions of primary care presentations from the flu alone potentially every year. Then we add RSV to that, and now we've added COVID to that. And every year COVID's going to be something we consider in addition to the flu and RSV. But we're seeing lots of other things. Norovirus is one. In the last couple of years, we've seen a lot of mycoplasma and whooping cough or pertussis as well. And now we've got measles and all sorts of other things as well. So it's a really crowded space. And so that means in a resource-constrained environment where we want people to come and get advice about vaccines and get access to get tested, etc., it's really hard. And so, we are in for a tricky winter, I think.
Speaking of combos, is there any progress being made on a combo vaccine? COVID, flu, maybe COVID, flu, RSV?
I like to think there are some upsides from what we went through with COVID, and I think it has advanced a lot of vaccine development. And so now there are heaps of combination vaccines. And here at the Mater, we're trialling a few of those. So COVID flu, RSV, and even some with human metapneumovirus in it, where we haven't had an approved vaccine. And, that's probably the virus severity-wise, it's just below those other 3. So it'd be great to have a vaccine for that. So, yeah, there will be combination vaccines. Like all these vaccines, we can't recommend them or say they'll be available until we've got the data to prove that and they're approved by our regulators. So that's not the case yet. Whether it's this year or next year or the year after, it's hard to say. But I think that'll make a big difference. The biggest thing, of course, and we'll be talking about that a lot at the time, is it's going to be really hard to know when to recommend those because the seasonality of all those things doesn't overlap exactly. So, yeah, we're going to have some interesting conversations, but, yeah, the combination vaccines will come.
So much work being done in this area. What about a universal flu vaccine?
Lots of really good work being done, and I think we're getting much more advanced in some of our techniques with vaccines that might be something we're getting closer to, but that's been tried for a long time. It's a really, really difficult thing to do. So I don't know if we'll ever get a true universal vaccine. I think, the next big steps forward with flu is we're going to have combinations. We're probably going to have very soon vaccines that don't need to be given by a needle and syringe, so patches, things you can put on the skin, which will be a big step forward. And then maybe an intranasal vaccine. So we've kind of got one of those, but that's going to improve. So again, we can spray it rather than having to inject it. So lots of great work happening, locally and here at the Mater even on a lot of these things. But, for now, the main focus, I think, has to be on recommending the vaccines we have because they're already excellent, but just underutilised.
And that's something that you've been doing very publicly for the past few years. We've been talking about your public role and talking about all of this. Just from a personal perspective, you do a lot of talking about it. How you're feeling about it and how much work do you actually do sharing this message with the broader population?
Yeah, thanks. Look, there's so many important messages that I think aren't easy to find for people. And this is feedback that I get often is that, there's a lot of noise. So I guess my approach, and whether I do this or not, I guess is up for other people to decide. But I just try and get what I think are the important messages out there in a way that hopefully most people can understand. And, as I mentioned, we've got great vaccines. They are safe and effective, or we just can't use them in this country. And the underutilisation of these interventions has a direct impact on what we see, whether it's COVID, flu, measles, etc. And so, we do have to try and combat a lot of the misinformation and lack of information by trying to get good things out there. And I try and help in a really small way in that regard.
Well, thank you for all the work that you do, and thank you so much for joining us on sMater today. Before we go, though, we have a little segment called The Checkup. So, surprise, we have 5 quick questions to ask you, and Maria will ask you, and they're questions about you to give us an insight into the man you are. So you ready to go? This is to
Let's
be
go.
quick 5.
Great.
Alrighty. What was your first concert?
Oh, probably Pearl Jam.
If you could impart one piece of knowledge on a medical student, what would it be?
Look, I think just to let them know it is a hard road ahead, but it's a really enjoyable one. And if you put the work in, it's an amazing career.
Who was the last person you FaceTimed?
Oh, FaceTime. Oh, I'm Android, so I don't have FaceTime.
You Android.
I guess Skype, which now doesn't work, but my parents. My parents live interstate, so I virtual call them all the time.
And what TV show best portrays your profession?
Look, probably reflects a bit of my nerdy approach, but I like Scrubs.
It's a great show.
What's your secret superpower?
Oh, gosh. Secret superpower? I don't know. That's a hard one. I've never thought about it like that. Might have to take a rain check on that question. I'm not sure.
Yet to be discovered, the
To be
superpower.
discovered. Yeah, exactly.
Paul, thanks again so much for joining us on sMater.
It's a pleasure. Thanks for having me, guys.
For our listeners at home or in the car or having a well-deserved break between patients, thanks for tuning in.
See you next time on sMater.